where the experts meet. Online learning, practical and sweet. Every Saturday, 9 a.m. Central Time. YouTube, Facebook, X, and LinkedIn. Online.
Hey, welcome everybody. This is Uro-Nurse, just in case you didn't know. I'm Vic Senese, and welcome to the show. Hey, if you're new to the show, or if you've been a person watching us all along and you haven't liked and subscribed, what are you waiting for? Like and subscribe. We've got a great show today. Today, we're joined by one of Europe's oncology nursing experts, Leann McLaughlin, Uro-Oncology Clinical Nurse Specialist. She has recently been accepted to the NICE Guidelines Committee. For those of you that don't know what that is, it's the National Institute for Health and Clinical Excellence, to update the national guidelines for the UK on diagnosis and management of prostate cancer. Leann's coming to us all the way from Scotland, so it's going to be neat to have somebody from here with an accent different than my Chicago one. Today, Leann will take us deep into the current landscape of prostate cancer screening and prostate biopsy protocols across Europe. Welcome to the show, Leann. Welcome. How are you doing?
Thank you, Vic. Thank you so much for the lovely introduction. And thank you for having me on your show. It's a real honor to be asked on. That was a lovely introduction. So feeling good. Happy to be here. Thank you.
Good. And just for folks that are listening from the US, what time is it over in Scotland?
So it's 3 p.m. here in the afternoon. It's a nice sunny afternoon in Scotland for a change. We often have rain. So yeah, just a bit later than you guys.
That's all right. You guys need the rain to grow the peat so you can make the scotch, right?
Yes, absolutely. Yes, that's what we do mostly all the time here.
All righty. I'm going to switch it over to your slideshow, so take it away.
Perfect. So, hello everyone. Thank you for joining today. So yeah, I've been a urology nurse for 6 years now. Previously a trustee at the British Association of Urology Nurses, and currently an advisor to 2 prostate charities in the UK, Prostate Cancer UK and Prostate Scotland, and recently just joined the NICE Guidelines Committee, as Vic has pointed out. So a fun fact about me, I very nearly never came into nursing. At the time of applying to nursing, I had 2 applications in my hand, and one was to college to do makeup and beauty therapy. So my career could have went a very different pathway. But due to taking this pathway, I was recently invited to a royal garden party with King Charles to have some afternoon tea for my services to patient experiences. So I'm not sure that would have happened if I had went down the makeup and beauty route, but I guess you never know. So let's get started. So I'm hoping by the end of this session, you'll be able to describe the EAU approach to early prostate cancer detection, understand how risk stratification has changed patient selection across Europe, certainly in the UK, and explain the role of pre-biopsy mpMRI. And you should also be able to compare transrectal with transperineal biopsy. And then to be able to appreciate the role of the clinical nurse specialist throughout the patient pathway. So why does screening matter? Well, it matters because it's the most common cancer in men, and there's an increasing incidence. So 1 in 8 Caucasian men will be diagnosed with prostate cancer in their lifetime, and that risk increases to 1 in 4 for Black men. And then we have to consider those men who have brothers, fathers, or sons with prostate cancer. The risk increases by 2.5 times. And here in the UK, prostate cancer is now the most commonly diagnosed cancer, with more than 64,000 men diagnosed each year, and 12,000 men a year die here in the UK from that. It's the second leading cause of cancer death in America, with around 333,000 new cases a year, and the incidence continues to increase annually. It's the 4th most common cancer in the world, and global cases are expected to reach 2.4 million annually by 2040. And we know that early detection of prostate cancer is critical because if it's detected at an early stage, confined to the prostate, the 5-year survival rates are almost 100%. And even with stage 3 prostate cancer, around 95% of men will survive 5 years or more. So the PSA dilemma, we all know PSA, or you may not know, but PSA isn't actually a diagnostic tool. It's not something that can actually detect prostate cancer as such. It's a tool that can be used as part of the puzzle that can lead on to further discussions and investigations. So the benefits are, when it's used, we can have an earlier diagnosis for men. We have reduced mortality when men are going to have PSA testing done. And as I've said, they can have more curative treatment options, and there's opportunity for that when cancer is detected early. The harms that it can do are that we can have false positives with PSA. Men can have BPH, so an enlarged prostate. They may have had a UTI that's not necessarily been picked up if they weren't symptomatic. Issues like prostatitis, inflammation in the prostate, and even recent sexual activity or vigorous exercise can raise a PSA, and recent urological procedures can do that also. So there's also a risk with PSA that men can be overdiagnosed. They may have a very low risk indolent prostate cancer that would never actually have caused them any harm in their lifetime. And men have gone on to have unnecessary biopsies, which can cause anxiety. Men can be overtreated, and that in itself can cause anxiety. You'll have men perhaps on an active surveillance pathway who nothing ever really changes for them, but they've got that anxiety, having their bloods checked every 6 months. And for those men who develop that anxiety, sometimes active surveillance just isn't the right thing for them, and we have to consider that. So who should have a biopsy? The EAU has moved more towards thinking who is genuinely at risk of clinically significant prostate cancer, and every step in the diagnostic pathway is designed to improve that decision making. As I've said, PSA we're taking as part of a jigsaw, if you like. It's not diagnostic, it's used as a guide. Then we have the DRE, sometimes not so useful in general practice, but certainly useful in the hospital for us to help ascertain if there's prostatitis, if that man's uncomfortable on examination, finding it very tender, painful. Are we feeling obvious nodules? I always explain to people, you know, prostate, if you take your hand and you've got this sort of soft fleshy part, you should be feeling that soft fleshiness. You should feel a nice central sulcus, nice smooth contours on the edge of the prostate. What we don't want is when you start to come round to the knuckle and you're feeling that hard, firm nodule, and that absolutely would warrant further investigation. We have to consider family history because we know that men are 2.5 times at risk if they do have a brother, son or father who has prostate cancer. So we're taking that into consideration as well to risk stratify and ascertain, should we be investigating things further here? Ethnicity, because that risk increases to 1 in 4 for Black men, and that has to be taken into account. And life expectancy as well, you know, in clinic, you can be seeing men and you're having to think about their comorbidities. So is it appropriate really to put this man forward for further investigations? Do they perhaps have multiple comorbidities, COPD, diabetes, previous heart attacks, ongoing angina issues? You know, you're trying to work out, will this man survive 10 years? Because if not, you have to think about, okay, we can do an MRI, which might then lead to a biopsy, but what benefit are we going to bring that man? Are we going to actually do more risk, do more harm essentially than good by, you know, doing these tests that do carry risks? And will it be of benefit in terms of, would this man be radically treated for prostate cancer? And we have to always think and bear these things in mind. We have MRIs to determine whether there are significant lesions, and I'll go into that separately on another slide. And again, we're considering things like PSA density and I'll talk to you about that on the slide about MRIs as well. Risk calculators, they are used throughout Europe. They're not something that I use in practice. They're not commonly used, certainly within my practice in Greater Glasgow. But they are used throughout Europe, so they are a tool that can be used to work out what would the patient's risk of significant prostate cancer be. And there are some common ones more commonly used, such as the Rotterdam risk calculator. And if you look that up, you'll be able to see exactly what that involves and what areas might be using that. And we have things like biomarkers to consider as well. Again, I have to say I'm not an expert on biomarkers. They're not routinely used within the NHS, but some men do pay privately to go and have their biomarkers checked. And there are some that are more common than others. There's one called a 4K score. Also within a PSA, some tests will look at the total free PSA and the bound versus the free PSA to determine, is there actually a higher risk that this patient has prostate cancer. Stockholm 3 tests are becoming more popular throughout Europe, which uses a PSA and another marker called an HK2, and also considers 2 proteins to help assess the risk. But as I say, it's not widely available, so it's not routinely used across the board. So MRI, why is it performed before a biopsy? So with MRI, apologies, it was a PROMISE trial from 2012 to 2016 that established that MRI could spare about 27% of men from unnecessary biopsies, whilst detecting over 90% of significant cancers. And that was a trial that looked at 576 men across the trial, and that led to an update in the UK diagnostic guidelines. There was another trial called the Precision trial, and that showed also that MRI before biopsy helps men to avoid unnecessary biopsies and find more harmful cancers that would likely be significant. So we have things within an MRI to consider. There's something called a PIRAD score, and that's a score that goes from 1 to 5 to look at the risk that lesion carries, with 1 being very low risk and 5 being very high risk. So for example, PIRADS 1 and 2, if you see a lesion, if you see something that says PIRADS 1 and 2 area on the MRI, it's not very significant, then you can often just rule that out for biopsy. You'll then come to PIRADS 3, which means indeterminate. It's a 50-50 chance of something being here. And that's what then leads us on to considering the density of the tissue. The density is a calculation of the man's PSA divided by the size of the prostate, and it gives you an overall density figure. That density, if it's over 0.15, that's the significant number that we're looking for. So if I'm saying to a man at clinic, you have a PIRADS 3 lesion, the density is 0.17, for example, that's where I'll recommend a biopsy. And these tools really help to guide us, to tell us, should someone actually have a biopsy or not? PIRADS 4s and 5s were more likely to find something clinically significant, and we would absolutely always say, yes, we should go to biopsy with PIRADS 4 and 5. So sometimes you have to add an element of clinical judgment when you're looking at an MRI and discussing that with a patient, because we need a word of caution here. PIRADS 5 can actually be prostatitis. It doesn't always mean there's necessarily cancer. And PIRADS 1s and 2s, believe it or not, can actually still have cancer, because you get cancers that sort of hide from the MRI, if you like, and they're not so obvious. And that's where the clinical judgment perhaps of the DRE and a combination of looking at family history and ethnicity can come into the discussion here. But the MRI certainly is reducing inappropriate biopsies by giving us these sort of risk categories with the PIRADS score. Sometimes when you'll see an MRI reported and they'll talk about a Likert score, and that's fine, that's still in use as well. More widely, it's PIRADS scoring now, which stands for Prostate Imaging, Reporting and Data System, and that's what's used by the radiologists. But Likert scores are still in use as well, and they are also scored from 1 to 5. The reason I mentioned have caution when you're discussing MRIs with patients is because MRI is still not a definitive diagnosis. You need that further information from those biopsies. And I have once made the mistake of saying to a patient with PIRADS 5, where it looked like actually there was extracapsular extension, so it looked like the area was going outside of the prostate. I'm highly suspicious. I'm really sorry. I think you've got prostate cancer. And actually, when I took this patient's tissue, it turned out that he had something called granulomatous prostatitis. It is a very tricky prostatitis that can greatly mimic prostate cancer on MRIs, cause very high PSAs. And so now I've never made that mistake again. I just say to people, we don't know for sure until we have that tissue. So thinking about the transperineal biopsy pathway, you know, historically it was always truss biopsies that were carried out. I've seen a big difference even in this over the years combined with that MRI. Again, Vic will know this when he comes back on. I worked in a clinic 12 years ago and I was in an endoscopy practice, and one of the rooms we had done flexies and truss biopsies. And I always remember the urologist coming in and he would just sit and give the patient their PSA level. It's high. I suspect you've got cancer. Let's consent you and hop straight over here into a truss biopsy with the ultrasound machine on the other side of the room. And I used to see him actually do what a finger-guided biopsy, where he would put his finger in, feel the prostate, perhaps feel the nodule, and guide the biopsy needle up the side of the finger to biopsy where he could feel the difference. Vic might be in the background laughing about this old technique, but we can chat about that when he's back on. So the difference here is truss biopsies, they go through the rectal wall, they're potentially introducing flora, bacteria from the rectum straight through into the prostate, which of course carries a higher risk of infection. And we have to use antibiotics for a truss biopsy for that reason. And with antimicrobial stewardship and increased antibiotic resistance, you want to try and reduce that, because more often than not, the antibiotics used for truss are fluoroquinolones, which carry quite significant risks on their own. Truss biopsy can't reach anterior lesions. It meant historically some men are having to come back for second biopsies if there's concern that we've missed a lesion, if the PSA continues to rise and you think they need to come back. And that's a big deal for a man to come back and have that done again. So transperineal, we're going through the perineal skin. There's no particular requirement for antibiotics. Considering why this movement was made. So, during COVID, obviously theatres were shut down, general anaesthetic use was much reduced because of that reason. He didn't want airway procedures happening, for good reason, understandably. And at that point, things started to shift, particularly in the UK, towards transperineal biopsy with local anaesthetic, because they realised you could do this safely and comfortably with local anaesthetic from a clinic room without any need for general anaesthetic. It also gave access to the anterior region of the prostate, and also apical lesions can be quite difficult to reach, and it gives better access to those and then carries less risks of infection. It has to be said that whilst I am currently on the NICE guideline committee, I'm not advocating for either biopsy style, because this is something that will be under review using the best latest evidence. So what's my role? What do I do in amongst all this? I am in a highly autonomous role here in the UK. We vet the patient's referrals from the general practitioner or family physician. And by vetting, what I mean is triaging. So that letter comes in saying this gentleman's been found to have a high PSA. Can you review him, please, and decide what's the best pathway? So I'll decide based on that letter, looking at the patient's history, what is the most appropriate pathway for the patient. Can they go straight to MRI? Is there comorbidities? Are there cognitive issues? Was there a previous UTI? Do I maybe want to repeat that PSA? Do I want to do a DRE and feel that prostate first? And I'll decide on straight to MRI versus a clinic review in the first instance. But I'll book that MRI if it's appropriate, and the patient will then go into a telephone review, or more commonly, to speed up our pathways as part of faster diagnostic pathways, giving patients a lot of results by telephone, running a lot of telephone clinics. So I'll see the patient at Rapid Access Clinic, face-to-face for those men who need a face-to-face review that MRI and help the patient to understand and interpret that outcome. Sorry, apologies. So what we're doing there is we're making a joint decision on the biopsy requirement. I'm discussing with them the PIRAD score, the density of the tissue, and also assessing their safety for the procedure. Do they have multiple comorbidities? Are they on an anticoagulant, for example? Discussing stopping that with them when it's safe to do so. Testing bloods if they're on warfarin. Do we need an INR? All these things, but also counselling the gentleman on what's that biopsy going to look like, what will happen at the procedure. I'll take a drink, otherwise I will keep coughing. So what we're doing is assessing that patient holistically within that clinic, looking at all their needs. Some men will say to me, what does this mean for afterwards? If I do have cancer, what does that look like? I'm a carer for my wife. I'm a carer for my children. I'm self-employed. I can't afford to be off work. And all these things need to be taken into consideration for that man, because these are the conversations that we take forward into the multidisciplinary team meeting, because it's us as nurse specialists who discuss that patient's care. And these things are important to patients. This is their life, this is their quality of life, and they absolutely have to be taken into consideration. Men will weigh up their treatment decisions based on these things, these lifestyle issues. Perhaps saying, I can't afford to be off work. I would rather have hormone therapy. I can't take surgery. I can't afford 6 weeks out. And it's our job as nurse specialists to take this on board. So we book the required tests. We book the biopsy, bone scan if needed, CT, chest, abdomen and pelvis, an ultrasound perhaps of the urinary system with a flexible cystoscopy if there's been issues like hematuria, further bloods, urines. And then we also carry out the biopsies. At the moment, I do truss biopsies, and I'm making a change towards TP. So I'm still just finalising my training on that, as I started that as a project with Prostate Cancer UK 4 years ago to try and improve my own practice and gain new skills. So then it's our role to consent that patient, decide are they able to consent, and then we're prescribing any therapy required like antibiotics if needed and local anaesthetic, for example. We give those biopsy results, we book further tests if they're required at that point, and add patients to the MDT meeting, and then discuss the patient's case ourselves also, and give the patient the results from that and commence them onto treatment. So there's a lot of education and counselling within that role, which I see as a really important part of the role. We're supporting patients with their psychological needs, supporting them and their families, because we can't forget that there's a family, a wife, a partner, children on the other end of this as well. And we're there to help prevent treatment regret by providing information and advice on treatments for patients so that they're fully informed and feel that they have the best up-to-date evidence they can have to make their decisions. And we're supporting patients afterwards to manage those side effects also. Patients have our number to call in for advice, and we provide advice and referrals to other services if needed. Really, we're there to oversee the pathway and ensure a streamlined service and great continuity for patients as well. And I feel that's where a CNS role is really vital. particularly within cancer care. We deliver quite individualised information and education for patients, as you've heard, based on their own life circumstances. So we are that first point of contact, certainly here in the UK. We are the most consistent contact for the patient. They always have our number to come back to us, and we're that ongoing source of support. As I say, we build rapport with those patients so that they feel they can trust us, and in turn we're providing that reassurance and empathy, and giving them the best evidence that we can. We're providing clarity at a time when men may never have presented to a hospital before. They may never have required hospital treatment. This could be a first presentation with something. Sometimes the bloods are often taken as part of another workup for something else, and the doctor thinks, oh, I'll just check a PSA as well. So it can be a time of real shock and fear for men, and a time of confusion where they really don't understand what's happening because A, they didn't really know what the prostate was, what it does, or why that blood's being tested. And then some men come to you and they don't understand that the PSA may not necessarily mean they have prostate cancer, so they can be really frightened at that time. We play a key role in empowering patients and their family members and helping them understand everything from imaging, pathology, staging, the diagnosis, and the treatment options. We really coordinate care across the multidisciplinary team. We're a liaison, always a central point of contact for everyone so that there's never missed communication, because we know communication is usually one of the biggest reasons for complaints in healthcare, because patients have felt things weren't communicated to them. So we're that central point to do that, in touch always with the urologists, the oncologists, pharmacies, community nurses, general practitioners, families. So it's there essentially. We're there essentially to continue acting as that patient's advocate and support them. We always take that patient's opinion into the multidisciplinary team so that their voice is absolutely heard and their own choices are taken on board. And I have to say we have very supportive teams who always do take that on board. We're constantly tracking investigations, results, referrals, always looking out for scans, looking out for pathology, and trying to speed up pathways essentially. So I would say, as well as nursing, we are excellent coordinators in cancer care CNSs. We're always keeping on top of everything and trying to signpost patients to the best evidence that we can. So if there's any key messages from today, I would say consider that PSA should be a piece of the puzzle that leads on to further conversation and tests if it's required. Pre-biopsy MRI helps detect clinically significant cancer and determine if biopsy should actually be taking place, and reduces the chance of unnecessary procedure, taking into consideration all our parameters such as the PIRAD score, the density, and then considering those other risks, for example, such as family background and ethnicity. And then specialist nurses, we are central to delivering that patient-centred holistic care and consistency across the pathway. So where next? There's still a lot of ongoing change. I think there's still further improvements for sure going to be made in the prostate cancer pathway. We know we have trials going on at the moment in the UK. Certainly there's an organised screening trial called the Transform trial. So that's looking at how best do you do an organised screening for men, because it's historically been such a difficult topic, with PSA not being the most accurate thing to be using. There's a PRAISE-U trial that's throughout Europe, looking at more emerging tools for screening. That's currently going on at the moment in Europe, looking at risk-stratified detection for prostate cancer using PSA and risk calculators and MRI pre-biopsy. And then there are other things going on, such as consideration of genomic testing. There are areas trying that, looking at the DNA to see how would a cancer act, how aggressive would it be likely to recur. and then looking more at personalised pathways for patients. And then in some areas, trialling using AI for MRI interpretation as well. So I think the landscape's always changing in prostate cancer for sure, but seems to be changing quite rapidly. So thank you. As they say, that's all, folks, from me. Thanks very much.
Yeah, that was a great job. You really summed it up well. So when we had this talk coming up, I also decided to do a little research to kind of look at the Europe versus the United States and how we do things different, how we do things the same. And so I think one of the big things I found out was MRI before biopsy. You guys were way ahead of us at that. So I think now it's become more of the standard of care here in America, but wasn't as quickly adopted as it was by you guys over in the Europe.
I saw that from your EAU guidelines that it wasn't really the standard, but it looks like certainly you're making inroads to make changes now. So that's a great thing.
And I have to tell you, I've been in urology for 40 years. I mean, when PSA came around, what we saw was more prostate cancer diagnosed because there was more biopsies being done. The research is now coming out and it's looking at all this, and they're saying, maybe we were just over diagnosing and not really helping people, because mortality didn't really come down from all of our treatments too. So it's absolutely having these fine tuning things, I think, are huge. All right,
is amazing.
I got the wrong button. Too many buttons here.
And did you ever see that in clinic, Vic, where I spoke about the finger guided biopsy? Did you ever see that?
I was involved in assisting on those, and I thought that was a mighty brave urologist to put their finger. And I've seen a few of them come out with a hole in their glove and not their finger. So I'm like, that's way too. I got involved in when the trans ultrasound became a thing, because the docs in my group didn't know how to use a computer, yet alone an ultrasound. And that's where I studied ultrasound to do that part. All right. So transperineal versus transrectal. So I think that you guys are pushing over to the transperineal approach faster than we are too.
Yeah, it's certainly taken off since COVID. As I say, it was really London who started with TP biopsy and managed to eradicate TRUS fairly quickly in a movement that they called Trexit, as in TR, transrectal exit. It really took off across London, and before too long they had managed to completely eradicate transrectal biopsy, and that then sort of became a gold standard throughout the UK to follow, where you started to see more and more health boards moving towards transperineal. TRUS is still used, it's still got its place, it is still used. As I say, I'm still carrying it out myself, but moving towards the transperineal side of things for sure.
And if you've done enough of these ultrasound transrectal biopsies, you've had to come across a patient who bled, and it's hard to stop because the rectum is such a big area to try to tamponade off the bleeding and infection. I mean, people get septic from this, so it can be scary.
I have had patients present back with sepsis. You check your results the following week, you check on how the patient's been doing, and they've ended up in the hospital for a few days, so it has happened, and it's horrible when it happens. As a practitioner, you feel bad, you feel awful, you try and think through, is there something I could have done to negate this? Is this my fault? Was there any other precautions I could have taken? And it's scary. It's a scary scenario for people to end up in as well. And certainly from the bleed side of things, anyone who's done this procedure, you do have those big bleeders. No matter what you do, you've maybe just gotten a bit too low, very vascular prostate. Sometimes men with very small prostates actually can bleed a lot more, and you're a bit more cautious in how many biopsies you're taking. So it does happen, and you then find yourself in a scenario managing that patient as an emergency,
So you guys are winning. You're ahead of us, but hopefully we'll soon catch up. Now here's where America kind of has gotten in front of the Europeans in looking at these advanced biomarkers, risk calculators. think that's kind of somewhat new for you, right?
Yeah, that's certainly not something I'm used to using, and certainly in the NHS, it's men, if they want further testing with biomarkers, they're more often paying privately to do that. It's not something that's introduced as part of the pathway. And again, with risk calculators, I know they're more widely being used across Europe, but it's not something within our guidelines to absolutely include in our pathway. So that's certainly looking at a lot more advanced, yeah.
Yeah. And I think you made a good point in saying that none of these are able to say, aha, you need a biopsy because this is positive.
Yeah.
This means you're at higher risk, but it could be prostatitis, other
Yeah.
things that are causing it. So
Yeah, absolutely. It's taking everything. It's like a jigsaw, isn't it? You're really having to piece everything together, and that's where I think your advanced practice comes in. You're able to piece all that together and holistically assess that patient, considering their own background as well. And that's our role, really, isn't it?
And I think the one thing that at least we're changing in our approach is before it was, okay, you need this. The physician said, this is what you need. You did it.
Yeah,
Now it's more, let's talk about your risk. What do you get patient
absolutely.
input on it. I think that's really important because as you said,
Absolutely.
people have different lives that they need to,
Absolutely.
can't be off of work. And,
Yeah.
how risky is not, waiting and just
Yeah.
watching things.
Absolutely. And you'll know yourself, Vic. You get those men in clinic who will say to you, I don't want this. I'm fine.
Yeah.
I've got no symptoms. What's it looking like on the MRI then? And they'll say, look, leave me alone, basically. I'm quite happy. You can monitor my PSA if you want. Check me out in 6 months by all means. But my lifestyle is
Right.
good and I would like to maintain that quality of life. I don't want to end up potentially on hormones and be fatigued and tired and have other issues. So yeah, it's
Sure.
very much
I mean,
taking the patient's consideration, their own
absolutely.
choices into
Yeah.
consideration. Yeah.
So again, biomarkers in prostate cancer care, US got you guys by all of our things: 4K score, PHI, ExoDX, Select MDX, ISO-PSA, PCA3.
There's so many. My
Every time
goodness.
I know
I wouldn't know where to start.
it gets confusing. Yeah, being out of now that I'm no longer in practice, I have to keep up with all the research. But
Yeah,
between
absolutely.
that and the new therapies with all these checkpoint inhibitors and all this other stuff,
Mhm.
it's good and bad. A lot of stuff you got
Yeah,
to learn nowadays.
yeah,
Again, comparing the philosophies of the EAU versus the United States, we're getting into the more shared decision making.
yeah,
I think you guys are more organized in doing risk adaptive screening,
yeah,
but you're using the MRI sooner,
yeah,
more preferential towards the transperineal biopsy and
yeah,
fewer unnecessary biopsies, which I
yeah,
think is where the US needs to start looking
yeah.
at going.
More often than not now, when I'm triaging, it's straight to MRI unless I spot comorbidities or cognitive issues, if they're suitable, straight to MRI from that PSA. Yeah.
Yeah. All right, great. So we did get a couple questions come in. I want to bring those up. They'll come up on the screen here. But Katie Bortel asked, does the primary doctor order the PSA and at what age? And when do they refer to you?
So the primary doctor does organise the PSA, but not as standard. It's usually the man has presented to the general practitioner with new urinary tract symptoms, for example. They've went in, they've said, I've got nocturia, I'm up all night urinating, I'm having some dribbling, I feel that the flow is poorer. And that will initiate a conversation at the GP. Sometimes men are more informed, as every patient can be, and they will say, I want a PSA, I would like a PSA. And they're entitled to do that over the age of 50 in the UK. But that warrants some counselling. GPs have to counsel patients on that. Do you understand there can be false positives here? So that a degree of counselling then takes place. But if that PSA comes back and it's raised for the man's age, And they've ruled out a UTI because that's one of the first things they'll do as well.
Mhm.
If there's any symptoms there, make sure there's no UTI, because there will be a false elevation in that PSA. If that's all been ruled out and, the gent is under 70 and that PSA is over 2.9, they would then be referred on to us, and that referral would come in. If they're sort of 70 and over, we're looking at a PSA over 5. So yeah, based on the level, the GP will then refer into us and say, I've found that this PSA is 7.6. Can you assess this, please? Yeah.
So it's interesting. So in America, if you're a 50-year-old or older man, you're going to get an automatic PSA put onto your blood work once a year.
Wow.
Yeah,
Wow.
that's how deep in we've gotten into PSA. 45 if you're African American. So
wow.
yeah.
Well, excellent. That's absolutely fantastic. Some men in the UK have to really
But
push.
the question is it so fantastic? Again, are we overdiagnosing? That's the real dilemma right now.
No, there is that dilemma. As you know, the trials are going on at the moment in the UK as to, what's the best way to set up an organised screening. So there's nothing established as yet. But what we find in the UK is that some men have to really push to get a PSA. Some men want one, they ask for it, they have the conversation, and they can struggle to get one. Sometimes, depending the area, the GP might say, well, no, there's no need for that. Why would you want to go and do this?
Yeah.
And that's not a criticism of sort of GPs in the UK, but it's probably just that historically they know there is a lot of overdiagnosis. But we are sort of moving towards now, men shouldn't have to push to get a PSA if they want one. They should be able to have that discussion, that counselling on what it could mean, and should be able to get one. Yeah.
All right. We have another question that came in from Tabo. I really love your holistic approach and the pathway used for your patients. Your role is so important, and I wish my clinic could adopt a similar approach. Well, it's more of a compliment than a question, right?
It's very difficult though. Sometimes, there are clinics, and even in Europe, it's not established across Europe that every service uses a CNS the way that we do in the UK. There are some European countries where, it still wouldn't be appropriate for a nurse to be biopsying or requesting onward tests. Every country is different. It's certainly not a standard throughout Europe that every nurse does the same. So it can be very difficult if you're trying to bring in change to a practice. You really have to spend time chipping away at the people who make the decisions, and that can be hard when you feel, oh, I'm just one of the nurses, what can I say to these people at the top? But it's about bringing in the evidence as to why that works, why it's a better pathway, why it's a faster pathway, why there's more continuity in care, why it's a better service for the patient, because they have this constant access to one-on-one support almost on the telephone, and someone who's overseen that whole pathway, so never has any confusion about where the patient is at or what's going on. And certainly if you want information on any of these sort of pathways, I'm happy to provide my email address to be contacted,
Great. And then we have Tiffany Reckling from Little Rock, Arkansas. We use the same pathway at my facility in Little Rock, Arkansas. It's an academic institution. So they're following the same pathway. I'd be interested, Tiffany, are they doing transperineal or transrectal ultrasounds in your field? Maybe you can put that into the comments. But yeah, it's a lot of great comments. We've had a lot of people watching today. So I guess we struck a nerve, huh?
Excellent. Well, that's fantastic. Hope it was helpful to some of you.
It was. Yeah. I think it's always good to get a different perspective of how things are done. Sometimes we get comfortable with what we're doing is the best, right? Especially America, we think we're always the best, but there's some difference. I gave a lecture. This was years ago when prostate infections, post prostate biopsy infections were like going crazy. And I was part of a task force to look into that. And one of the things, and I was presenting to an international group, I had mentioned that we give all of our patients a Fleet's enema prior to biopsy. Well, the group from Europe went crazy. You Americans are nuts with this. Why are you putting patients through an enema when you can't sterilize a rectum? I know you can't sterilize a rectum. I said, in America, there's a difference. I says, you can't get guys to take off of work and then cancel out because you found that they're constipated. You got to treat them just so you have a clear rectum.
Although, interestingly, if we're doing transrectal biopsy in the UK, we use iodine in the rectum before the biopsy. That was an EAU recommendation to reduce coliforms. So we always do that if it's transrectal.
Yeah. It's kind of been met both ways here in America. A lot of guys jumped right on the using iodine to try to, but again, you can't sterilize a rectum. It's just impossible. I don't care what you do. It's not going to happen. So
we can try.
We make ourselves feel good sometimes. I think that's really what happens.
Yeah.
All right. So Tiffany did get back. We are transferring to transperineal biopsy.
Oh.
Hey, way to go, Tiffany. I think that as a male and someday could face the needle, I think that's the way I would prefer it. Tavo said, thank you. Great presentation. Tavo's one of our regular fans. I see her name all the time. So we've got a great fan base. Well, Leann, I'd love to have you back on the show another date, because now you know so well how to do a podcast, right?
Yes, this was my first time doing a podcast.
We've made you a professional here on this show.
I was extremely nervous, but you made it a very comfortable experience, Vic. I have to say, so.
I tell you, if you didn't tell me this was your first time being on the show, I would have said you've been doing this for a long time. You were very comfortable. You gave a great talk. So, hey, I'm going to put a little promo out for next week's talk.
Discover how rapid molecular diagnostic testing is transforming modern urology care. This informative episode is hosted by Vic Senese and joined by Dr. Stephen Goldberg, Chief Medical Officer at HealthTrackRx. Learn how next morning infectious disease results are helping healthcare providers make faster, more accurate treatment decisions that can improve patient outcomes, reduce unnecessary antibiotic use, and streamline clinical workflows. Join us on August 1st at 9 a.m. Central Time to learn more.
So yeah, that's going to be next week. We're glad to have Dr. Goldberg joining us. I think this is one of the newest things that we started to see here in America. I don't know if you guys are doing it, but these rapid results for urine cultures. Urine culture used to be a 3-day wait. You know, you'd see somebody send off the urine 3 days later after they plated it. And heck, I used to do those myself in the office. Yeah. It takes 3 days to grow everything out. Well, now you can get results almost instantly. And that's a lot of these tests. So it's really going to be interesting to hear what they say. So, all right. Well, it's been a pleasure having you on the show. Everybody's putting in thank you on the comments. So they're all grateful for your time. Go out and do something fun this afternoon. For those of you here on the America side, this is our morning. We just started. So let's all go out and have some fun. And we'll see everybody next week on your.
So here's to the mornings, the coffee, the monitor glow, to the wisdom he shares and the folks that he knows. Saturday is special when Vic's on the stream with 40 years of knowledge and a head full of dreams.